Welcome to Hydration Lecture Series again. Today I have a very special guest, Professor Clark from Canada, and I would like to say a few things about him before we start the presentation. Professor Clark is a professor of medicine at Western University of Canada, and he's a scientist at the Lawson Health Research Institute and director of apheresis, consulting nephrologist at the London Health Science Centre. He has been leading studies in prevention of progressive kidney disease, both in vitro and in vivo, animal and human studies, as well as observational and randomized controlled trials. He has more than 382 published articles, and he's the chairman of the Division of Nephrology at Western University, Canada. He's the 2014 president-elect of the World Apheresis Association, scientific co-chair of the Medical Research Council of the Kidney Foundation of Canada, and he was the 2012 recipient of the National Medal of Research Excellence of the Kidney Foundation of Canada, the Queen Elizabeth II Diamond Jubilee Medal, and I can stay here, I think, for the rest of the day and say more and more accomplishments. But instead of doing that, I think I would let Dr. Clark speak about his passion, which is chronic kidney disease and the effect of water. Thank you very much for coming here. Thank you.
Thank you, Stavros. Thank you very much, Dr. Kavouras. It's lovely for you to invite me to this wonderful university, and I must say you have a great setup here. It's a pleasure to be here and a pleasure to meet many of you people. So we're going to talk today about water, and we just said CKD, the final frontier, because in epidemiologic terms, the final frontier is really a randomized controlled trial. So it's not quite as exciting as striking out into the great beyond. In terms of questions, for those who are online, they can get Dr. Kavouras via this email, and he can convey your questions to me, and I can try to answer them. In terms of conflict of interest, as we all have, I do receive speaking honoraria, flight accommodation expenses, and RCT grant support from Danone Industries, and also speaking honorarium from the American Society of Nephrology, the Canadian Society of Nephrology, and Alexion. So why a water intake trial? Obviously, starting today with a glass of water for the World Kidney Disease last year is an interesting concept, but it's not because I'm a Canadian and Niagara Falls is in Canada. It really began with a problem, as most often research does. And in 4 days in May of 2000, there was 134 millimeters of rainfall, which resulted in flooding in water. And at the time, a small community in southwestern Ontario, all of their water supply was coming from the shallow well, which was adjacent to a cattle farm with E. coli 157H7 in the herd. And as you know, that's the toxigenic form of E. coli that really cows tolerate, but it generally kills most other animals, including man. So the well at that time was unmonitored, and there was a follow-up inquiry by the ministry, and the two operators are found to have improper practices and systemic fraudulence. Actually, they were testing the water in their own homes, not testing in the wells, and they were not adding chlorine residuals. So what happened, unfortunately, at that time is that there were 2,300 cases of enterocolitis over a 3-day time period. So a small community of about 5,000 people. This is the emergency, this right here, this is their hospital in the emergency ward. And there were 7 family doctors in this area providing this hospital with support. And they would go by rota in terms of the emergency department. And when an emergency came in, they would call the doctor who would be in his office probably 2 or 3 miles away. And he would drive in if it was really emergent. If it wasn't, he would see the case later. And they would see about 10 cases a day, which is typical of a very small community. But in that time period, they saw 750 cases over a 72-hour time period, which really did extremely stress their system. There were 65 hospital admissions, 27 recognized cases of hemolytic uremic syndrome, and there were 7 deaths. So our admission, in terms of the Ministry of Health, they asked us if we would go and identify and treat individuals at risk for complications, because obviously there is significant risk for complication if you have hemolytic uremic syndrome second to E. coli 157H7, and also to study the long-term burden of illness. And so we went to the town hall, this is their town hall, and met with the community actually in 2 meetings over, I guess, about a 6-hour time period. One evening, I introduced the medical team that I was bringing with me, and also threw it out to them in terms of our plans for actually studying what had happened to them, our plans for screening them, and our plans for treating them if we identified problems. And so that was an interesting direct interaction. Obviously, there were a lot of things that resulted from that interaction. We had about 22,000 patient interactions with about 4,000 interventions in the population. But really, we did develop sort of a clear idea of the long-term risks for hypertension, kidney impairment, and cardiovascular disease after these individuals had suffered gastroenteritis from drinking water contaminated with E. coli 157H7. But like all things, you get serendipity, and the effect by which one accidentally stumbles upon something truly wonderful, especially when looking at it for something entirely unrelated. And that usually means you might be roughly in the right place at the right time. But if you recognize the phenomena. And so what we had done, because we had collected urine volumes and 24-hour urines for protein as part of our assessment in this patient population serially over a 7-year time period to determine if there's anything evolving, it also gave us a chance to look at their volume of urine, because we thought we were harboring the illusion that if people hyperhydrated, they might have more protein excretion, which was in fact the reverse of what happened. So there was the decline in kidney function was significantly slower in those with higher versus lower urine volumes, which was a surprise to us, even after full adjustment for all the baseline variables we were looking at, which were about 12. And we could actually demonstrate a dose-response effect, because if you're in an observational study, we pick up associations, really. And we can't really correct for selection bias. However, if you do get a dose-response effect, it does suggest that causality is more likely, but doesn't really prove it. So what is the biologic possibility of increased hydration being a renal protective mechanism? So when life forms emerge from the proverbial primordial slime, I wish the primordial slime was like this. In the beginning, there was AVP. So life forms could now survive in a terrestrial habitat without continuous contact with water. So vasopressin is a very important part of that issue. But long-term, while essential for water regulation, vasopressin has vasoconstrictive effects, and increased plasma levels have negative effects on renal hemodynamics, blood pressure, and ventricular function. So vasopressin infusion increases proteinuria, renal plasma flow, and hyperfiltration, which is the hallmark of progressive renal injury, hyperfiltration, while administration of AVP antagonists reduces proteinuria and lowers blood pressure. So theoretically, in the short term, great, probably provides you with flight and flight reaction, but if you want to live to be 70, having a lot of this around might not be a good thing. So how does this translate long-term in chronic kidney disease in animals and men? Well, obviously, animals can drink water. Lise Banker and Nadine Bouby in France in 1990 published their experience in a wonderful trial in which they looked at the 5/6 nephrectomized animal, and they gave them increased water versus a control group with normal water, and they suppressed the AVP, they measured the AVP suppression, and these animals' blood pressure, proteinuria, renal hypertrophy, glomerulosclerosis, and tubular interstitial fibrosis was modified considerably by increased fluid intake. So increased water intake in this is sort of the universal experimental model of progressive renal injury, the 5/6 nephrectomy model. So it was quite interesting, but not everyone jumped on that at the time of its happening. So in chronic kidney disease, vasopressin inhibition in adult PCKD slows progression. And that's been shown by a wonderful study in the New England Journal recently. But that probably is a different mechanism. That involves the actual effect of vasopressin on stimulating cyclic AMP and causing cystogenesis. So that's a different mechanism. As well, severe dehydration with its high levels of AVP have been reported as a cause of Mesoamerican nephropathy, which is more recent information, although not probably as clean as information as we would like, in the sense that there are other factors that could contribute to this problem. So what about increased water intake in non-PCKD chronic kidney disease in man? And really there are 4 observational studies that have been done. Obviously, Stripley's study, our own study using the NHANES database, and Stripley again, with Satoni Palmer, doing a cross-sectional study, and then our own long-term longitudinal study. So in terms of summarizing this information, you just have to believe me, or you can go and read the papers if you'd like to. The prospective cohort study of 2,000 Canadian adults without kidney disease, higher urine volume predicted slower renal decline over a 7-year time period, which is quite significant. The 2 cross-sectional cohorts of our study with the NHANES database of Americans and Stripley's study with Australians shows an inverse association between self-reported water intake and CKD. In other words, higher intake of water, the lower your risk of chronic kidney disease, which was statistically significant. So, and chronic dehydration from heat stress is most likely cause flexing the epidemic of chronic kidney disease in Central America. But these are observational studies, biased by unknown selection or misclassification. And that's always the way. So that's why we came to the water intake trial to carry out both a pilot and an RCT to see if we could change the issues in terms of having a better idea if increased water intake may benefit kidney function prior to an RCT. So we wanted to examine the safety, feasibility, and quality of life of asking adults with chronic kidney disease to increase their water intake in a pilot trial. So we always have to do that before we do an RCT. We also always have to register our trials at clinicaltrials.government. Otherwise, you can't really publish them in any journal, any impact journal. So pilots have to be done that way as well as RCTs. And now they're even getting into observational studies being pre-registered, which is moving the game along. So what about safety? Well, I'm sure you all remember this report of this very sad case of this young woman who went on a radio show that was, I think they were giving away a wee for a wee, was the name of the show, Wee for a Wee. And she drank, I think, about 4 liters of water in less than an hour. She left the left the radio station, and she was dead within an hour. So she had actually coned because she had severe water intoxication. So there is the issue of safety. What about efficacy? So there's only one study, interestingly, on pre- and post-study questionnaire in patients who are asked to drink increasing fluid intake. And this is in a study about renal calculi. This is published by FUS. And what they showed is that 11% of patients are unable to increase their fluid intake if asked. 35% had daily urine volumes less than 2 liters, and 30% reported they could only increase their intake during non-working hours. So there seemed to be some real issues about fluid intake that we had to consider in terms of looking at a study. So why quality of life? Increased hydration can decrease appetite, increase urination, although I must say I would profit from the decreased appetite routine. That would be very helpful for me. But they can increase urination, particularly nocturia, people with chronic kidney disease, affecting their sleep patterns and quality of life. So the results of the pilot study, the hydration group 24-hour urine volume increased by 0.7 liters per day, and the control groups decreased by 0.3. So the difference is about 0.9 liters per day, which was statistically significant. So we could, in a 6-week pilot trial of patients who were coached to drink more water versus patients who were coached to drink their normal intake. The reason why we use coaching on both sides of the equation is that in any study, you have to inform people fully of why you're carrying out the study. Otherwise, it's a bit dishonest. And in fact, your REB will not approve it. So in a situation where you tell people that the reason we're looking at this is because it would appear that the majority of people in the literature observationally have shown that there may be a benefit in increasing fluid intake. Most patients are pretty smart, and they'll all start drinking more. So you get regression to the mean very rapidly. So you have to coach both sides of the equation when you use informed consent. So there are no significant changes in serum osmolality or sodium concentration with no serious events, and there was no significant change in the quality of life reported. So that study was published in the BMJ. What about the biologic possibility in terms of the study? Well, we also measured cobeptin, which is a stable analog of vasopressin. So we did that during the study as well. And what that shows is here we have the control and hydration, and we can see that you have the pre- and post-randomization. The hydration groups, urine volume goes up, and the control group actually goes down a little bit. You see the changes in baseline. You look at the copeptin levels, and you see a rise in copeptin. In the control group, well, it stays the same, and actually your hydration group, your copeptin level goes down. And your urine osmolality is, in terms of the post-randomization, urine osmolality goes down in the hydration group, and which is a change of 0.76. But these are not significant changes. But when you look at the correlations between 24-hour urine volume, copeptin, EGFR osmolality, albumin to creatinine ratio, and urine serum sodium in the 28 patients in the pilot study with chronic kidney disease. And I guess the other reason we should have mentioned to you is as nephrologists, we forget to explain some of our things because we just presume everyone knows. People with chronic kidney disease, the fear is that because they are unable to clear a normal osmolar load, that if you give them too much water, they're more likely to get water intoxication. And so that's why it was the fear of us doing this study. The reason we wanted to select the patient with chronic kidney disease is that they are progressing more rapidly. So we need a smaller number of people to actually demonstrate a phenomena. In other words, to pick up a signal, you need a smaller number of people. If you look at a population which is progressing more rapidly, at least that's what we theoretically thought. So when we looked at the copeptin levels, you can see there's a good correlation between urine volume and copeptin. It's a negative relationship. The larger the volume, the lower the copeptin, and vice versa. Same urine osmolality, there's a positive correlation. So the higher the urine osmolality, the higher the copeptin level. And EGFR has an inverse correlation. Serum osmolality has a positive correlation, as one might expect. And there's enough albumin to creatinine ratio also has a positive correlation. The higher the copeptin level, the higher the albumin to creatinine ratio. So we had some markers of renal impairment which were traveling as we might suspect if this was to be a causal mechanism. We were kind of surprised with the small numbers that we were actually demonstrating these findings. So in terms of the biologic possibility, there's a modest increase in water intake was associated with a significant decrease in plasma copeptin. At 6 weeks, copeptin was inversely correlated with EGFR and positively correlated with urine protein. So that was sort of interesting, not a sort of a game winner, but an interesting thought. So I guess what we were most happy about is that it was safe to do this in this population, didn't affect their quality of life in an adverse fashion, and that we could actually efficiently separate groups, because the big concern is that, yes, you can do this study, but everything's going to regress to the mean, and you're not going to be able to demonstrate this in a randomized controlled trial. So we had at least preliminary evidence that we might be able to do that. So we designed this randomized controlled trial to test whether increased fluid intake can slow renal decline in CKD patients. And following successful completion of our pilot trial, we began our main trial on April 8th, 2013. We had to hold up for just a 2 to 3 month time period to resolve some logistics before we actually started to enroll patients. And the logistics were about making sure that people had access to water, and if not, we had to have access to bottled water. We preferred they use tap water. And all of the little wrinkles that were knocked out at that point in time. So this is a parallel group randomized controlled trial. The trial is conducted at the Kidney Clinical Research Unit at London Health Science Centre. The enrollment will continue on to the end of June 2015. Participants will be followed for 1 year after study entry with active coaching and 1 further year without coaching. So we talked about coaching, and we'll give you a little more detail about what that entails. So prior to randomization, participants complete a short survey and undergo a physical examination. Blood samples are taken at baseline at 3 weeks after randomization, and at 3-month intervals over the follow-up. A 24-hour urine sample is collected at baseline and again 6 and 12 months after randomization. So our target enrollment is 700 patients. The eligibility criteria include stage 3 chronic kidney disease, which means that you have EGFR between 30 and 60 mils per minute or 1.73 meters squared, and proteinuria. So we definitely have people with chronic kidney disease. Detailed eligibility criteria are outlined below. Actually, I'm not going to do that because we could, yes, unless you like to read small print, but we'll be happy to talk to anyone about the eligibility criteria. So in terms of our power analysis, from our previous observational study, we noted that we were seeing a difference of 0.7 to 1.3, actually 1.3, between the largest output group and the lowest output group in terms of their annual progression of loss of kidney function. So to overpower the study, it looks like you need 289 in the 0.7, and you would need 85 per arm in the 1.3 difference. But whenever you're doing an RCT, what happens is that whatever you're using as your base for change to do your power analysis, it never occurs again. It's always less or worse, usually less than you've observed. So to overcome that, you need to overpower your study. So that means that you use a larger number of subjects to enroll in your study. So we set our target at 700, which would be really beyond the 3 standard deviation range that we would expect with trouble. So randomization, participants are randomized in block size of 4 by computer-generated randomization to the hydration or control group in a 1-to-1 ratio, stratified by gender and center. The initial randomization, because we did it by gender and center, produced an imbalance in the group 1.3 to 1, and we have then adjusted the ratio to rebalance the groups over the next 6 months. So what you have to do is when you're enrolling people, you have to make sure that you're not creating an imbalance by your original algorithm. These are the baseline characteristics of the population. These are the tests that are going to be happening through time. So they're getting their demographics, their food frequency questionnaire, their health history, height, weight, blood pressure. We're looking at creatinine, sodium, copeptin, hematocrit, cystatin C, which is probably a more sensitive way to measure GFR an estimated GFR in the general population. And hemoglobin A1C, 24-hour urine samples for creatinine, urine sodium. Again, creatinine, to just establish that a 24-hour urine sample is a 24-hour urine sample. And urine sodium and osmolality of urine to creatinine ratio, and random spot urine, we do osmolarity as well. Statistical analysis data are summarized using standard descriptive statistics. The normally distributed data are summarized using means and standard deviations. Non-normally distributed data are summarized using medians and interquartile ranges. We followed an intent to treat analysis, so all randomized subjects were included in the analysis and analyzed according to group assignment. Comparison between groups were made using the independent t-test or Mann-Whitney U as appropriate. So what about informed hydration coaching? Well, it's really based on your osmolality measured in spot urine samples taken at 3 weeks after randomization, and again at 3, 6, and 9 months after randomization. However, our clinical coordinators who met the patients initially and after they'd been screened and met them and enrolled them, and they called them every month to see how they were doing and to see if they're in the hydration group, whether they'd increased their hydration. So they developed a dialogue, which is a very effective way of ensuring adherence with these patients. And also when they had the test, they could contact them if their urine osmolality was less than 300 and they were in the hydration group, they just say maintain your current fluid intake. It was 300 to 500, they'd increase their fluid intake by 1 to 2 cups of fluid a day, water a day. If it was greater than 500, they'd increase the water intake by 2 cups per day. And again, in the control group, we did the same thing, but in the reverse fashion, because we had to coach people so they wouldn't regress to the mean, because they're very bright individuals who want to have better health. We also used Larry Armstrong's urine chart, which Stavros has also been involved with in terms of the urine chart, to actually have the controls or the hydration group to actually pin this to their toilet and just see if they're actually in the range they're supposed to be. And again, when they're called by their coaches, they ask them about their urine charting. So to encourage study retention and adherence to the intervention, research fellows now maintain monthly contact with all participants. They also send them birthday cards on their birthdays and Christmas cards, and whatever religious. So you want to establish a relationship with these individuals because people are doing this of the goodness of their hearts, and so you can't pay subjects to participate in a research-approved, REB-approved study. So all participants receive individual consultation with study dietitian in person or by phone throughout the study. We also conducted informed hydration coaching based on a 24-hour urine osmolality, which we showed in Table 2. And participants in the hydration group received 20 vouchers per month for 1.5-liter bottle of water, redeemable at Food Basics. That's a particular food chain which is available throughout the entire southwestern region, so everyone can have access to it. That's what took the extra few months of sorting out. And in terms of the primary outcomes, so unfortunately today we're not going to talk about any primary or secondary outcomes because that would obviously affect our study. But we will tell you about other factors which we think are significant and interesting. So in terms of our primary outcome, the thing that we're most interested in is change in kidney function. So the change in estimated glomerular filtration rate between baseline and 12 months. That's really our primary outcome of interest. Secondarily, we'd like to look at the urine albumin creatinine ratio because that's considered to be a fairly sensitive test to predict progressive renal injury and also to predict who's hyperfiltering and who's not, since hyperfiltration is a feature of AVP excess. Rapid renal decline, we also wanted to look at the population who are losing more than 5% of their kidney function per year to see how they fell out in terms of hydration or lower hydration. Body mass index, because again, there's some evidence that increased hydration is associated with weight loss, which would be a nice thing. I should be partaking in the study myself. Blood pressure, change in blood pressure between baseline and 12 months, because there's some evidence, again, observational, that increased hydration may actually lower your blood pressure, but that's not substantiated. In hemoglobin A1C, again, there's some suggestion from Roussel's work that a change in hemoglobin A1C occurs in people who actually have increased hydration. In other words, it reduces their hemoglobin A1C. So you have better glycemic control. Copeptin, change in vasopressin between baseline and 12 months. And that's really a secondary outcome, but we wanted to look at that also in terms of the relationship between copeptin and kidney function to see if there's a correlation. In other words, that's sort of the final real test, because a randomized controlled trial tells you about what happens to human beings under these circumstances. But theoretically, you want to know, is there a mechanism that explains this? So if so, even if the people are in the control arm and they're drinking lots of water, because we're going to have some people doing that, if we actually just look at people in terms of their kidney function and copeptin, we get a correlation regardless of the group they're in. So the study statistician, we have a data safety monitoring board, and the new rules of running data safety monitoring boards are fun because you can't know the people on the data safety monitoring board, so you can't influence them. They have access to all your information. You don't. And if there is a problem, they will contact you. And if there are any adverse or clinically important events, the study, they then review with you. And so this happens every 3 months. And to date, there have been no safety concerns. But they have the right to stop the study if they perceive there is a safety concern. Or if, in fact, your hypothesis is proven and they feel that there's no statistical benefit in continuing, they'll also interrupt the study at that point. So this is really to protect the subjects in the study. So to date, or actually we're a little bit further than this because we've now randomized 360 people. So this is 277. But anyway, you always have to approach a lot of people when you're doing a study like this, because I would say most people don't like collecting 24-hour urines. And if you say, there's no incentive, we're not paying people to do this. We're just saying, we think this might be a benefit. It would be nice to know the answer. It might benefit you indirectly, but we certainly can't guarantee that. Then you find that with that sort of thing, that you'll get about 40%, 30% of people 35% of people who actually participate, which is good. You consent them, But you randomize less than you consent. A, because there's a time lag, because they have to do another 24-hour urine, and B, because about a third of those people won't do the next 24-hour urine. You've sort of done an indirect adherence test, which affects the generalizability of your results, which you have to express later on, but it's reality. And this is what's happened to date. Actually, we have 360 in now. There's no real baseline difference between the groups who are hyperhydrated versus control in terms of a host of variables. The advantage of randomization is eventually, but this is the good news. So we can't look at our primary outcomes or our secondary outcomes, but we can look at urine volume, which was not a primary or secondary outcome, to see if we can actually, is our protocol working? And what this shows clearly is that at 6 months and 12 months, we get very good separation between the groups in terms of their urine volume, between the control and the hydration group. Actually, there's quite a nice separation between them. So you can see it here graphically, probably better than in the table. But what you're seeing clearly is that your control group is staying the same or slightly less than when they started. Your hyperhydration group has significantly increased their urine volume. So this report summarizes interim results for key variables in the chronic kidney disease water intake trial for data collected from April 8, 2013 to October 20, 2014. We now have actually a further update, but we didn't incorporate the information. They're still crashing it. But during this time, we enrolled 393 participants. We've now enrolled actually 480 participants. 360 have been randomized, and probably another 60 will be randomized within that cohort. And we're going to continue to actually enroll. And we've also expanded to a third clinic in Oakville, Ontario, to have even a higher monthly enrollment rate so that we can achieve our 700 subjects by the end of June of this year. So that data collection is going well. We have less than 2% missing data on key variables, which is always a nice thing to have. And study withdrawals are less than 10%, which is fairly typical for any RCT. So to our knowledge, this is now the largest clinical trial of increased fluid intake in patients with chronic kidney disease. The successful separation between groups with respect to fluid intake, in fact, the 12-month separation was 1.2 liters, means that we will have scientifically reliable data on the association between fluid intake and kidney function. So we don't know what that's going to be, but it should be reliable in the sense that we will have tested our hypothesis. The answer to that, I really don't know at this point in time. I feel like I'm sort of, so I just want to say water is wonderful, but there can be excesses to fluid. And just make sure this doesn't happen to you on your wedding day. But anyway. So any questions? Yes?
Start with, you mentioned doing some of the cross-sectional studies that
Yes.
initial kind of images for this randomized control trial. I think one of the things that people usually talk about are other behaviors that tend to group with high fluid intake. Do you have any kind of anecdotal or
I mean, if you go to a general population and sort of look at characteristics that correlate with people who drink more fluid,
other healthy behaviors?
Well, some of them are healthy, some of them are not. Female gender correlates with increased fluid intake. And we think that women are maybe a little more health conscious than men, which I guess is no surprise for people who are looking at gender-related data. And the other thing is, interesting enough, is smokers drink more water than non-smokers. Whether they get thirsty because they dry out we don't know. But that was the only thing we noted statistically significant in looking at over 2,000 people in terms of any baseline associations with the hyperhydration, those who had high urine outputs versus those who had low urine outputs.
So nothing as far as, increased physical activity, increased vegetable intake?
We didn't look at increased physical activity, but we suspect that might, but we didn't have that information. I think if that was looked at prospectively, that would be interesting, because I would suspect that would yield a correlation. And I think the other thing too is that when we're looking at a population, we're looking at a population from, 18 to 86. But I think if you were looking at a younger population, you might see some greater correlations between if we had a much larger younger segment, I think we might have seen. I think younger people are drinking more water. At least if you look around most rooms and most lecture halls, and just as a generalization, a lot of people are carrying water bottles, but they're not over the age of 50. I would think they're definitely under, but that would only be an impression. Sorry.
How much do you increase the increase in the group?
It depends upon your gender and your body weight. So if you are a female and you're a large female, we would go to 1.25. If you're a male, we would go to 1.5. If you're a small male, we would go to 1. So men have a larger osmolar load than women. So we skew our data to actually give men slightly more fluid than women to deal with the reality of their osmolar load. And that's been demonstrated on a large, everything like NHANES and a variety of studies have shown that men have which I'm sure you're all aware of, have a greater osmolar load than women. So we adjust the formula when they're randomized depends upon their weight and their gender. So what is the least we would recommend? Probably a liter, and the most is 1.5, in addition to their intake. And we're getting about 1.2 liters, but if you take in, it's probably close to what we need, because we're going to have a number of people at 1 liter. I don't know that exactly, but we'd have to look at that post hoc. Yes?
So, a follow-up to Matt's question here. So that is the outcome variable that you're looking to control, or the mechanism behind your intervention. Is it reduced urine osmolality that may affect the change in chronic disease, or is it reduced decrease? Or are those two one and the same?
I guess we'll be able to tell you. We'll be looking at that. So those are secondary outcomes that we'll be looking at. We think that they're probably hand in glove, but we can't be 100% certain of that. But certainly when people have looked at I didn't mention Perico's studies, which were published in 2013 on the 5-6 nephrectomy model, so follow-up from Bankir's study. But they actually maximally sort of inhibited the renin-angiotensin axis in these animals. And then they randomized them to receive an inhibitor, an AVP inhibitor. And the AVP inhibitor enhanced the slowing and progression of the renal impairment. So an effect beyond renin-angiotensin blockade and attributable to the suppression of AVP. So we think that would suggest it's more likely going to be AVP suppression, but we can't be certain of that. At least there's more experimental evidence to support that.
Osmolality is a kind of a method to kind of claim that, or
exactly.
Or how much.
Because in the pilot study, the urine osmolality, sort of the higher the AVP level, the higher the urine osmolality. So there was a good correlation there. So we suspect, we don't know, but we suspect that there will be a correlation when we look at the outcomes. We think. So I wish I had an answer, but in a year's time, I will have an answer. Yes?
Question for you. Can you explain why there's gender differences in urine osmolality if we look across populations, since women have always lower urine osmolality?
Yeah, because men have a greater osmolar load, but don't necessarily drink more water. Women drink more water. So I think
you can observe this pattern even in young age, even like
I'm not sure. I didn't know that. I don't know that because I've only looked at adults, so I'm not sure that's true. But I think it depends upon when the muscle mass differences. I would think it depends when they start to get androgens. In other words, when the difference in muscle mass starts to become apparent. Because I would think that by age 6 or 7, they're pretty much the same because they're not getting that androgen effect, so their muscle mass is probably pretty similar. I don't know that, but I would think so. It would depend upon when their androgens are really kicking in for the male. bigger turnover of protein. I think. But it would be interesting to do a study like that. I don't know. Do you know? You're much more familiar with this area than I am.
I have observed greater urine osmolality in 24-hour sample with kids starting from age of 7, 8, even from younger age. The boys have consistently higher urine osmolality than girls. That we don't expect to have big hormonal differences.
Do boys eat more than girls? I mean, even at a younger age, I don't know. I mean, I'm just wondering, because those osmoles have to come from somewhere.
We have actually Perrier in our lab for Ben.
Yes.
You can't just put on paper that shows that exact same relationship. 100 milliosmoles per kilogram greater.
But not for kids, though.
It's for adults.
Yeah, for adults, yeah. But you're saying the same thing occurs in kids. So that's interesting, because that sort of that would be worth exploring.
Any other questions?
Well, thank you for being patient, and
Thank you so much. Appreciate it. Thank you.
Hi, I'm JD Adams. I'm working on my PhD in exercise science here at the University of Arkansas. Exercise science, simply put, is understanding how to maximize the body's health and performance. I'm interested in the science of heat and hydration in both healthy people and people with medical conditions. Let me show you what students and faculty are studying in the Human Performance Laboratory at the U of A. Concussions are a serious concern for athletes of all ages. Dr. R.J. Elbin studies the neurocognitive, physical, and psychosocial effects of sport-related concussion in youth and college-age athletes. His research focuses on identifying factors that influence concussion risk and recovery. Whoa! Dr. Michelle Gray does research on functional fitness to help older adults live independently as long as possible. She studies muscular power, an aspect of fitness that gets to the heart of the matter. Maintaining adequate muscular power helps prevent fall injuries, the leading cause of both fatal and non-fatal injuries among older adults. Well, how'd I do?
JD, I've got good news and bad news. The good news is you survived the test. The bad news is the worst reading we've ever seen.
Man, I need to work on my core strength. Dr. Barry Brown created this device called the AB test to quantify core strength. His research has shown that sit-ups measure abdominal muscle endurance, not strength. Building the core reduces lower back pain and enhances athletic performance. Wow, there's some fascinating stuff in here. Diabetes begins with insulin resistance in the skeletal muscle. Dr. Nicholas Green is researching how we can use exercise to combat those effects. His research is working toward ways we can prevent diabetes and related diseases or lessen their severity. Dr. Tyrone Washington's research focuses on how different physiological conditions, such as obesity and aging, affect muscles' ability to recover from damage. Nothing like water to quench your thirst, but too little water can have a big impact on a person's health, exercise performance, and cognitive function. By artificially inducing thirst and monitoring the body's response, Dr. Stavros Kavouras shows that even small degrees of dehydration can also affect kidney function, glucose metabolism, and hormonal changes. Man, this suit is hot, but researchers use it to study body temperature control. Dr. Matthew Gainio's research focus is on understanding how hydration and heat stress affect people with medical conditions such as diabetes and obesity. The findings from this research have implications for how to improve long-term cardiovascular health. Man, it's hot in there, but Dr. Brendan McDermott needs a heat chamber like this to do research on prevention and treatment of exertional heat stroke and hydration status in athletes. His studies can have profound benefits not only for athletes, but also people such as soldiers and those who work in extreme weather conditions. Well, what do you think? Pretty cool stuff, huh? Many of our graduates go on to work in clinical, sport, and academic settings. If any of this interests you, visit our website. You can be a part of the important research going on to help people live healthier lives. We look forward to hearing from you.